What I do, or Rehab Without Walls Neuro Solutions, is we work very much in conjunction with our docs, our physiatrists, our rehab specialists, neurologists, and we work in very much the same way. We take a team approach. It's very interdisciplinary. PTs, OTs, speech, cognition, MSW work, neuropsych, and we do the exact same thing. We take problematic situations, case studies, and sit down and really work out those details and figure out what it is that we're going to do. We work very intensive, aggressive therapeutics. A lot of times we're only in a case for 4 weeks, 6 weeks max, and we're really looking at what we can do solution-wise to stabilize the situation. So let me go ahead and, let's see. Now I went too far. So we're going to do a case study. Usually I don't start off with this, but with this group, case studies are sort of what we're doing. So we're going to start with a 53-year-old male. He was involved in a bicycling accident this year, and he had no loss of consciousness, but more than likely with his type of injury, we are going to see some kind of cognitive deficit. That's not what we were focused on in this particular case. His prior level of function, married, worked as a nurse. I always take that into consideration because I love working with our medicals out there. And very independent, very, very active, prior military, just an amazing gentleman. We were not working on any, he was stable as far as his surgery went. We didn't have any disruption, no going back and doing any kind of repairs after his therapeutic was over. He did have a fusion, but we had quite a few post-op complications, including, of course, a decline in respiratory that led to a trach. He went through some staph. He went through DVT. He started off his surgeries at Harborview, went over to University of Washington, and he basically spent about a month going through until he was transferred over to the University of Washington. And then he spent another month before he was sent into inpatient rehab. And he was quite successful. He did develop a UTI. He had some other situations going on that they dealt with pretty rapidly. They have to do some pretty aggressive passive range of motion when you are working with an ossification, which is what he did definitely have while he was at the University of Washington. Again, he was there for about weaning off of the vent for about a month or so, went to inpatient rehab, and he was discharged home stable. He was very stable. He was not at all independent. He was very dependent. But at that point, inpatient rehab is done. They've done what they can to get him to where, a lot of our inpatients, they are working on trying to get that community bridge built, that home bridge built. And this gentleman definitely did present at the time that he could handle outpatient therapeutics. He did go home with some home health, PT, OT. They don't generally like to take spinal cords. But in this case, he was working towards going to outpatient therapeutics. He was readmitted within 2 weeks for another UTI. And this really started with the digression in his goals. At this point, the patient he went home after the UTI with just the home health working with the antibiotics, the intravenous. But at that point, no other therapeutics other than trying to get him stabilized enough to go to outpatient PT-OT. And this did not happen. At this point, the patient slid backwards. He lost any kind of independent or work towards independence at this point. Very, very nervous to go outside of his home environment, round-the-clock care, to the point where he could not even, he digressed so much, he couldn't even do any kind of movement within bed for rolls or pivoting. So really, and I think a lot of it was his spasticity. kicked in to the point where he just really shut down. And that is where, because his goals for independence, especially with the bowel and bladder, with the movement, being able to handle his safety even within home, they were at a loss, really, of what to do. So we were called in, and this is what we work with the most. It's getting that stabilization, getting that safety, building that independence back within home. And then our goal also is to work back into the community setting. So this is what he looked like at admit into our program. So at this point, he was a max assist for bed mobility transfers. He was using a slide board to a hospital bed, but he was even dependent for car and uneven surfaces. So this is a gentleman who at this point really was self-isolating, mainly due to his dependence. He was not at a floor recovery stage. So at this point, we have 24-hour need for assistance, because at this point, he cannot handle any kind of a safety maneuver outside of a house. So he has to have 24-hour help. Balance, he's a ME.D with assistance, short and long sit, and he has to have upper body support. So his wheelchair mobility, he's supervised manual, even household surfaces only, and he is not able to access his community. So at this point, this gentleman cannot functionally go to outpatient therapy. He's already done his inpatient therapy. That's not a return. So he's done with that. So what do we do with this patient? Where do we go from here? And this is where we come in. Again, as we go on, as ADLs are needing 24-hour caregiver assistance. You know, that's very expensive. Not only is it expensive, but it's at the expense of what's going on personally for that gentleman. I mean, he has lost his independence. And that's what inpatient was working on getting him towards. So bathing, toileting, meal prep, he's dependent on everything. Medical management, dependent on everything. So this is where we step in. He's got everything he needs. So inpatient rehab has done a great job of making sure his equipment needs are there. Unfortunately, what we see in a lot of our patients that are digressing after inpatient rehab is that that equipment just sits there. They're no longer able to really functionally use, and they're certainly not progressing towards independent use of DME, and more sliding backwards to where they're not even wanting to, they're self-isolating, not wanting to even get out of bed. But he definitely had everything he needed. Okay, so this is where we step in. Now, these are the main problems that he was having that was literally working against his independence and moving forward and really keeping that self-isolation and depression going. Is, again, we're working with the problem with his blood pressure, both shooting up and lowering at really scary rates for him. His spasticity. So a lot of it is what we do is we get in there. Again, we're very aggressive. We're very intensive. We can do therapeutics at anywhere from 12 to 20 hours a week in the home, in the community, with the family present, where we're doing a lot of education. How do we work with these situations? How do we work with that spasticity? Is it a situation where we can help work with that patient to really understand how to even use the spasticity, how to use the muscle tone improvement within the spasticity. We also had a lot of problems that we had to work with as far as skin shearing, bed sores, and this is our outcome. By the end of our 4 weeks with this gentleman, he was back to building that level of independence. We were able to work with self-positioning. We adapted a bed rail to where he could now be independent or less dependent even within his bed situation, working on doing his own self-checks, which is a huge thing for our population of spinal cord patients. Being able to handle their bowel and bladder and their skin checks themselves is just a big boost in their self-confidence. He did, when we first had admit into our program, he did have 2 falls out of the wheelchair with a decrease of balance. We worked on not only in the house and in community setting of how to stabilize him within the wheelchair, but we also worked on that range of motion, keeping his feet on the floor for balance, working on ADLs performed with both hands for balance. So these are all things that we intensively do PTOT within the home and community, and working with the family as well. Big thing for him was independence with the bowel and bladder. At the point that he came back from his readmission with the UTI, he was just giving up. He was at the point where he was just having the caregiver do all of the skills for bowel and bladder, and that is going to keep your patient at home. They're not going to feel safe in the home and in the community setting, not able to leave the house without any kind of feeling of independence. So that was a huge, huge workup for our team to work on education, work on what it looks like for travel, what to pack, what to take, what to do prior to leaving the house. We don't want self-isolation with our patients. We worked on the adaptive equipment environment setup. Yes, he had the equipment, but no, he didn't know how to use it at home. It wasn't the right setup. And again, this is a medical person we're working with, but you still need that step-by-step instruction in the home. We worked on a catheter system at night, a different routine for the morning. And our outcome was that he was modified independent with bowel and bladder routine. He was mostly continent. He was able to travel outside the home, and he was sleeping through the night now. So this is a huge, you can imagine his life, huge, huge breakthrough for him, independence and safety at home, as well as just that feeling that he can now go out and conquer, which is what we want. This was the setup that we modified for his home use. A lot of times, again, our home health, wonderful as they are, our inpatient rehab, as wonderful as they are, really sometimes you need some specialized education to be able to put a spinal cord rehab to use in the home system. So this is what we do. This is our expertise. We modified the bed situation so again he could do his own turns at night. And as easy as this looks, this was not done. He was sent home from inpatient without the proper alignment of how to handle his own world, other than just having a 24-hour caregiver, which is what we want to get away from, if possible. More problems and outcomes, transfer again from soft bed to couch to car, changing the adaptive equipment that he was using, working on strength and balancing. That is a big part of what we do, and we do it very intensively. And we make sure family is involved. So it's not just reliant on a caregiver doing all of the work. We work on body positioning and really that education around what needs to happen safely for skin intactment, safety, the whole bit. Now, patient can watch a movie on the couch with his family. That's what he wants to do, and that's what we want to make sure he is able to do. He can sit in the front seat of the car with the wife. Community access, independent and basic transfers. So in 4 weeks, we were able to get this gentleman who wanted to just sort of give up back to a reality of what life is going to look like moving forward. ADLs, the dressing, education, training, body mechanics, leverage, material choices. This goes back to getting that family integrated into what's going on. Working with modified independence with basic dressing. There's our gentleman transferring from wheelchair to, well, that's his slide van. Great guy. One of the things that we work with in dressing is not using the bed. The bed was slowing him down. It was taking too much energy. Energy conservation for our patients is a big deal. We don't want dressing to wipe him out for the entire day. It's dressing and getting out of the house. That's our goal. 2 modified of just our basic adaptive equipment, using a zip tie to be able to allow him some independence in putting on his own shoes, making a loop for the socks, little things. But a lot of times these are not necessarily, checklist skills that are given to every patient and inpatient. It's really a modification of working with that patient so intensively at home for their particular needs. Problems and outcomes again, bathing and grooming, working with energy conservation. Should the shower really completely just wipe that patient out energy-wise? No, it's done in systems. Let's work on your timetable. Let's work on your conservation of energy. Let's figure out a good system for you and your family to be able to get through the daily routines, the daily living skills that are needed, and that really boosts the level of acceptance of the situation for our patient. Feeding and meal prep. This particular patient, his big goal was to return to activity as far as shopping and prepping meals for his family. He was the cook. He was the one that made the pancakes on Saturday for his family. Let's get him back there, and that's what we did. So once we sort of tackled a lot of the other situations, we were able to get him back out into the community, grocery shopping. The thing about our program is home health, as soon as that patient sort of darkens the front door, they're out. They are homebound. We are not. We are home and community. We will go with our patients to the grocery store, back to work, back to school, back to the YMCA, whatever needs to be done. We will be step by step with that patient to make sure that we are getting it done right the first time. Huge for him also was safety at home. Until that patient is able to safely be able to evacuate the home, they cannot be left alone. Well, when you have a 52-year-old man who is former military, a nurse, independent, this is a huge deal for him. Not only is it huge to be able to get out of the house, but it's huge for him to be able to stay in his own house. So working on the scoot independently so he can reach the phone, using modified situations to be able to get him out of the door, if the case may be. And then the last one, of course, is that endurance, being able to handle activities. So this is our gentleman working on our adaptive way for him to be able to leave the house. And even though this may seem rudimentary, unless somebody is walking that patient through that system, they are going to be dependent at home with somebody having to be there 24 hours. This is not what we want for our patients. We want them moving on with life in a great and safe way. So wonderful man. This was just a fantastic patient to work with. We also do work with depression. So when we have a patient that is sliding backwards, digressing, wanting to work on goals, a lot of times we are having to throw in that element of getting that social worker in there, working with the family and the patient. Support groups are huge for us, and we do hold our own when necessary. But it's just a matter of also working with struggling with that new identity at home. So now we've made great goals in our inpatient. We have some wonderful inpatient units, rehab units. But a lot of times when they get home, that depression will hit because these are the familiar areas that now are no longer accessible. So that's what we have to work with a lot. And for this gentleman, he was very, very active. The bike ride is what put him in the situation, but that was the one thing he wanted to do. Well, two things. Was to cook for his family again and to get back out onto the road. And he was able to ride at least 1 hour by the end of our therapeutics alongside his wife adaptively. First, we started off with the hand bike, getting him back into the routine. And then we went to the adaptive bike, and he was incredibly, incredibly successful at reintroducing activity into his life. So a little bit about our program, and I am just about done. So Rehab Without Walls is a neurosolutions program. We work with neurodeficits. We are home and community, comprehensive home and community treatment program based where that client lives, whether it's the home, the work environment, the school, the social. We have got therapists that are in Amazon right now, working with TBI clients or ABI clients, reorganizing and figuring out email, figuring out how to get from the parking lot, doing the mapping, the goal setting. So it's not just the home, it's getting them reintroduced back into the environment that they were used to. It's intensive. It's neuro rehab for adults, adolescents, and pediatrics. So we have an entire pediatric program, which in our home health system is sorely lacking. And this is such a needed emphasis for our PEDS clients. With our PEDS clients, yes, we work with spinal cord, we work with tumors, we work with ABI, we work with myocardial situations, all kinds of different situations within our pediatrics. Our pediatrics is also very specialized in oncology as well for those kiddos that cannot leave the house. They still need that PT/OT and speech to keep them going, keep them progressing. The results, integrated into interdisciplinary approach, focused results, outcomes, gains in safety and independence. Those are our big factors. Neurodeficits are definitely our diagnosis. Spinal cord, TBI, ABI, CVA, and complex orthos for those people that need that home and community support. A little bit about our functional outcomes. The admits, typically, again, a lot of our patients are coming out of inpatient rehab, and we are looking at a 60 to 70% that still need 24-hour supervision. They are not safe and independent at home. Upon leaving our program, we are looking at anywhere from a 15, well, our spinal cords are around 12% of not needing or still needing the 24-hour support, but that is even dropping down 3 months to a year after. Patients who can be left alone safely for 8 hours, whether it's just sleeping in a room by themselves and not having to have constant supervision. At admit, we are real low, especially with our spinal cords. People are still having to go in to watch, turn, make sure that they're repositioning, and we are able to work upon discharge of our program at around a 50% that are able to sleep for 8 hours alone without somebody coming in to do that turn. And finally, a lot of what we're looking at in our managed care these days is just a lower amount of time also in our hospital systems, pushing our patients through acute phase to inpatient rehab. It used to be that our inpatient rehab days could clock up to 100 days, and now our inpatient rehabs, some of our managed cares want them out at 30. So, besides going to maybe a secondary residential program or even a SNF for that 24-hour or having a 24-hour caregiver, this is an alternative. This is a resource, especially if you have a family and a patient that really wants to work on gaining that independence at home and community. This is a great resource. So there are several places in which we sort of put our program into the continuum of care. The majority of our referrals are going to come out of that inpatient setting, an awful lot. In particular, those patients that just are looking like they need that extra push to get into safety and independence at home. But we also have patients that are not qualified for inpatient. A lot of our TBIs that are just not able to perform at the level of therapeutics necessary to warrant an inpatient stay. They can't do 3 hours at a time. They can't stay awake. That's where we come in and do intensive therapeutics at home with the hope of getting them into an outpatient. And we'll even go to outpatient with them. We will literally go with them to outpatient so that that family feels safe, that patient feels stable, get them to outpatient, and so that we also make sure that they're actually going. A lot of times we have that self-isolation where they do not want to leave that house, outpatient is out of the question. Not because it's not, dictated by the physician, but because the patient just refuses. We also have other places where we take them out of residential, and in particular our specialty hospitals. If you are sending a spinal cord to a Craig Hospital in Colorado or a Shepherd, a lot of times we work very closely with them to keep that therapeutic going and get them back home safely. And we'll travel with that patient all over. My territory is the 4 Alaska, Washington, Oregon, and Idaho. But we will work with whatever we can as far as a Craig situation goes. We work very closely with them. Some of our referrals are coming out of inpatient, acute hospital floor, specialty hospitals, work comp, neurologists, discharge planners. Our national, our Washington Brain Injury Association sends us a lot of referrals, special need trusts, and of course our other therapists. And that's really it. We're here to sort of fill that specialized gap within the neuro continuum. When you have a problem patient or a patient that just is digressing instead of pushing forward, that's a great time to do some really intensive home and community.